Without further ado, let me introduce Dr. Tierney. We are so glad to have her here today. This is Public Health Dialogues for the School of Public Health, and this is our state leader, Dr. Tierney. And I think we should give her a round of applause. Next month is her one-year anniversary of her appointment. So believe it or not, she has been running the helm for exactly 1 year in November. She was appointed in this role by the Secretary for Health and Human Services. And 2 months into her role is when the chemical spill occurred in Charleston, which we all are aware of. And so she had to handle that right out of the gate when she just got appointed. Because of her work around that chemical spill, she was presented with the West Virginia Poison Center's Distinguished Service Award. And I would say that that's a great source of recognition, but because of that, that chemical spill, which they say it's the single largest man-made environmental disaster in U.S. history, she probably needed a bit more than that award, I would say. So as Commissioner and State Health Officer, Dr. Tierney's key responsibilities are to direct public health activities at all levels within the state to fulfill the core functions of public health. She works directly with 54 autonomous local health departments across West Virginia. And if you didn't get that, 54 autonomous local health departments, that means that she does not control those 54 local health departments, that they act independently, and she does her best to coordinate the work of those 54 local health departments across the state. She's worked for the Charleston Area Medical Center as a hospitalist physician and associate quality director. Additionally, as an attorney, she has worked in both the private and public sector. She has worked for U.S. Senator John D. Rockefeller IV and in the West Virginia Attorney General Office. She has also worked in the private sector as an associate and corporate general counsel prior to attending medical school. And for those of us who are really interested, I was interested in this, these are her degrees and where she got them from. She is an alum of West Virginia University School of Medicine from 2006. She completed her residency in internal medicine and pediatrics from West Virginia University School of Medicine, where she served as chief resident from 2009 to 2010. She received her JD from the George Washington University School of Law in 1992, and she holds a BA degree in psychology from WVU in May 1989. Please welcome Dr. Tierney, and let's give her our full attention. Thank you.
Hello, good afternoon, and thank you for having me here today. I appreciate it. As we get started, I will tell you I frequently forget to hit the clicker. I just get going. I think this is an important conversation that we're going to have today. I think there are many challenges facing West Virginia and West Virginians' health. And I have been spending this past year working for ways to empower communities to start to accept responsibility for the health of the community. So with that in mind, we will get started. So today I want to highlight some of my roles and responsibilities as commissioner. And as a state health officer. I want you to see how we on the state level work with subject matter experts. I want you to see how we link communities together, whether it's through data or through innovation or through collaboration. I want to look, as I said before, at some of the concerns facing West Virginia today. And there's I guess I've got about 90 minutes. I'm not going to take 90 minutes talking about this. I hope to spend about 45. We'll see how this goes. and then I have time to answer questions or to enter into discussions. So, as was alluded to during my introduction, this is sort of what it felt like from when I got appointed. Actually, I started November 1st and found out I had a presentation to the legislature on November 14th about my entire bureau. So it wasn't just one loop of the roller coaster, it was multiple. We were just sort of getting our stride when January 9th occurred. It's for me, it's the day that will live in infamy. It's not D-Day, it's January 9th. 2014. That incident involved 9 counties, approximately 300,000 West Virginians, which is 1/6 of our state's population, just to put that in context for you. And it is something that resulted in a series of new laws being passed that we are still working through to this day. A new commission has been set up. We're still sorting out what these new laws mean to us in public health and how we're going to implement them going forward. So I want to take a quick look at public health from the state level, behind the scenes. What is our defined mission? What is the purpose for the Bureau for Public Health? This is my bureau. Now, I know you can't make this out, but this is what I got to present to the legislature 14 days onto the job, as well as having to take questions for them, and they could question me about any portion of the Bureau. Or we have several hundred grants that we monitor as well. My budget is about $275 million, half of which come from federal grants. So if this gives you an idea of what we're talking about. At the very top, which, like I said, you can't make out, is the cabinet secretary. And underneath her is me. And then I have 3 deputy commissioners who work with me very close in the commissioner's office. And I have a director of public health regulations and an HR person. That being said, and that's because I have nearly 750 employees who work for the Bureau. My offices and centers are the smaller boxes on the side and underneath. It includes the Office of the Chief Medical Examiner. It includes Environmental Health Services, the Office of Laboratory Services, the Office of Emergency Medical Services, the Center for Threat Preparedness, Community Health Systems and Health Promotion, Maternal, Child, and Family Health, Nutrition Services, Health Statistics Center, Epidemiology and Prevention Services, School Health, Minority Health, Performance Management, Privacy, Health Informatics and Continuity, Center for Local Health, and Finance and Communications. And from that, I also have about 130 different programs that we run here in the state. And the breadth of this is amazing. When I took this job, I didn't realize how deep and big this went. But we were talking just outside before I got started, that my training as both a physician and a lawyer have uniquely helped me in this role. By statute, this person holding my job is required to be a physician. However, I would say 20% of my time is spent using my medical degree, and a good 80% is using my law degree. That's because we're developing policy, we're writing laws, we're interpreting laws, we're enforcing laws. And it's interesting. I'm trying to think of how to describe it, but it's interesting, though, when the two can come together and go forward. In a lot of ways, the chemical spill is a place where that happened. But I'm also able to use my experience as a clinical physician to think about how we approach West Virginians and about how we approach communities and how we start to look at some of these programs that we are charged with running. And I'll repeat this. For the most of my life, I was born and raised here in West Virginia. I am a West Virginian. And for my entire life, the health statistics, some of which I'm going to tell you today, have been exactly the same. They have not changed. We have been 48, 49, 50th, or in the on one side, or 1, 2, and 3 on the other side. None of it good. And nothing has changed. And we have spent millions and millions and millions of dollars, and nothing has changed. So I have the temerity to say, it's time to take a look at these programs. It's time to see which ones really are working and which ones are not working. And before we spend more money on things that aren't working, we need to start figuring out what we can do or what we can do different to make an impact. Continuing to do the same thing we have been doing for years is not going to accomplish the goal. I think we've proven that. You know, for 20 or 30 years and millions of dollars, it's not worked. A lot of people want to say, well, it's education. We need to educate more. I disagree. I use smokers as an example. I defy you to find a smoker today who doesn't know that smoking is bad for them. I think that's pretty well everywhere. Everybody accepts smoking is bad for you. And yet, we lead the country with pregnant women who smoke, and we lead the country with smokers. So, we've got to approach this problem, and it is a problem, differently. For a pregnant woman who smokes, has an underweight baby, that baby is more at risk for developing asthma and other respiratory problems and other complications from being underweight. How do we stop this? What is it that we can do to motivate somebody to stop smoking? It's not telling them smoking's bad for them. We've got to figure out how to approach this problem differently. And really, this is where you come into play. There's no bad ideas. We've all got to start thinking outside the box. Another thing people like to do is tell me how great things are working in California or how great they're working in Oregon. I can tell you from my clinical experience, if I walk into a room with a patient and I say, well, this works in California, I've already lost the audience. So we have got to figure out how to make the California program work for West Virginians. And it's not by quoting to them the stats or the statistics or telling them it works in California. We've got to figure out what's going to motivate that patient, that person, that family to make better choices. How can we help them do that? Is it building a community pool? Is it making sure they have sidewalks? What is it? What is going to be the key that tips us over? And we can finally start moving the needle in the right direction. I mean, I want to say to Tennessee and to Nebraska, watch out, here we come. And I don't want to just do it on the football field. I want to do it here in health. Of course, I want them to watch out on the football field as well, but that's a whole nother story. But these are the things that I need you to think about. You, the students who are in here from public health, you are the future. If you are from this area, you need to think about what's going to work in the community that you're from. And if you're not from this area, then you need to learn who West Virginians are. We are a unique breed. We're very proud. We're very self-sufficient. We'll give you the shirt off of our back, but we don't want you to tell us to do that. We're happy to offer it, but don't tell me. Another thing I learned as a clinician is if I was dressed as I am today and went into a patient's room, I had a lot of difficulty in getting information from the patient. However, if I was dressed much more casual, I could get all the information I needed and more, and we would be able to develop a rapport. So you have to take into account that portion of your audience as well. You have to think about, like I said, who we're trying to influence and how are we going to do that. Everybody looks to the state and wants the state to answer their problems. And the reality is the answer is not the state. As the state, I can lead and take it so far. But people in the communities have to pick up that flag and they have to be able to take it and make it work in their community. It's not enough to say, you know, we should be doing this, we should be doing that, because I probably agree with you. But the question is, how do we do that? And instead of just saying we should be doing this, it's sort of one of those, I want you to be part of the solution and not part of the problem. These things are always easy to say, but difficult to implement. I'll give you a water example. Wyoming County, to this day, Pincher's Holler, does not have clean water. I would say probably there's a large number of you in here never heard of Pincher's Holler and unaware that for the past 18 months, they've not had drinkable water. Now, Charleston was without drinkable water for a week. And, you know, the sky has fallen. Not to say it's not a big deal when something is put into your water, it is. But there are lots of Pincher's Hollers all over West Virginia that have barely viable water systems that are barely surviving. So for Pincher's Holler, it's a big deal. They need to tap into the closest community's water system. The reason it's taken 18 months is, I mean, the solution is easy, right? Tap into their water system. But the solution involves right-of-ways, easements, eminent domain, finding the money to pay for all of that, finding the money for the pipes to connect it, and to actually make it happen. And Pincher's Holler maybe does 50 families. So it's not been a priority on anybody's radar. So I just give you that as an example. You know, it's easy to say what the solution is. It is much more difficult to figure out how to get from point A to point B. And so if our new point B is to improve our health statistics, then we've got to figure out a new way to get to B. And that, like, literally, this is where your research that you do will be useful. This is where, when you think about these things, it's about how do I take the program from California or Oregon and make it work? So, all right, I guess we can go to our next slide. I will, let's see. I think we've talked about this. One of the benefits of me being in this role is when there is an emergency situation or something comes up that is outside of our expertise, I do have the ability to get those subject matter experts quickly, whether that's the EPA, whether that's the CDC, and the vast majority that is the CDC, ATSDR, the National Toxicology, NIH, et cetera. The good news is they do take our phone calls and they do try to help. And it's not just me. I mean, if it's somebody in my epidemiology office who needs assistance, those experts in those federal agencies are equally available to them. If it's water, they're equally available to the people on the ground. And that's really great. This one's about empowerment. I think I've touched on this. My overriding goal is to figure out how to empower communities, like Pincher's Holler, to work together to solve a problem. And I've talked about like the smokers and that sort of thing. And this is where we need to figure out what we can do to empower those communities. Okay, in engagement, we talk about data. I will tell you that the Bureau for Public Health is very data-driven. I've got lots of data in lots of places. My Office for Vital Statistics gathers data. Maternal Child and Health gathers data. We've got data. You want data? We've got data. You ask for, how many people smoke between the ages of 20 and 22, I can tell you. I can tell you what county they live in. I can tell you if they regularly go to a doctor or not go to a doctor. And we're a very data-driven place, and we try to take that data and use it in an evidence-based, best practice form to make good decisions. But data by itself is not enough. It's like, if we have the data but we don't use it in an effective way to help implement change, then it's just data for data's sake. And sometimes it really feels that way. So my goals, the goals of public health for the state of West Virginia, is we want West Virginians to be healthy, and we want them to be healthy in their communities. It sounds simple, but I think as I demonstrated before, getting from A to B can be a very difficult road. We have in West Virginia an aging population, new and more costly medical equipment and studies and medications. All of these contribute to increasing healthcare costs, and all of them create challenges for anybody with chronic disease. And we've got a lot of chronic disease here in West Virginia. So, once again, we have to help shape the environment. What infrastructure already exists? What programs are available? What programs work? How can the community address smoking? How can a community address obesity? How can we assist that community in addressing those questions? How do we make decisions and craft policy that will help guide that approach? We have to embrace the values of the community. We can't give the community our values. We have to understand what theirs is in order to make a difference. So it involves communicating effectively. I can tell you from this first year, sometimes I do that really well, and sometimes I don't. When I took this job, I was told I would not have to speak to the press. That was a big lie. And I've made, I think, virtually every rookie mistake you can make in talking to the press. The one thing I have tried to do nonetheless, despite constantly the next day saying, well, that was taken out of context, is to be honest. I don't know about you, but I do not live in a world of certainties. I live in a world of uncertainties. And maybe it's being a physician has allowed me to understand that I have to take the information that's available to me today and make the best decision that I can. And continue to do that every day. So I do that. There are not absolutes. I wish there were absolutes. It sure would make things a lot easier. A lot of times, it's our best guess based on the information we have. And so how do we effectively communicate that to the public? It is incredibly hard. Just out of curiosity, is there anybody in here who came down to Charleston to help with the Casper here today? No? Okay. A group of students did come down to help with our Casper, which is our community assessment following the water spill. And what I found was interesting was that they talked about when they came down to Charleston to do this. Now, they came in April. The water had been given an all clear at that point for over 2 months, and we had been testing at below 10 parts per billion for weeks. Now, 10 parts per billion equivalent is about 2 seconds in 32 years, to kind of help you understand what we're talking about. Or it's 2 drops in a 7,600 gallon tanker. Now, without a doubt, the water should have no MCHM. It's unexcusable that there was MCHM leaked into our water. But at that level, it's lower than many of the other trace elements such as arsenic or other things that in large quantities would not be acceptable, but in trace amounts are. But these students talked about when they came down that they brought water with them and that they used water bottles to brush their teeth and they used water bottles to wash their hair until that got to be too inconvenient and then they just got in the shower. But I found that interesting because we as their public health leaders had given them all the information we had explained our decisions, why we made those decisions, and yet they still felt a question as to the safety of the water. I don't want to have this misinterpreted that I'm somehow criticizing that. I'm not. As a matter of fact, if there's any criticism, it's for myself. Because it's clear we did not communicate effectively about the safety of the water. And that's a real failing. But I can assure you, it was not from a lack of trying. And what I found interesting is that these are my future leaders in public health, and yet they didn't ask the current leaders of public health about the water. And so it's a sign of how important communication is. And, I have learned tremendous amounts from that. The one reason I think I can sleep at night is I know I've been honest. I've not lied about anything. I've not hidden anything. Things have been misinterpreted. I hate, by the press, whether for the sensationalism of it, to sell papers, or because they legitimately misunderstood me. I'm not sure. But I'm going to live in West Virginia for a lot more years. My family is going to live in West Virginia for a lot more years. If I had any concern at all about the safety of the water, my family and friends wouldn't have been drinking it, and I would have been telling everybody in every way I could, don't drink it. Because, and this is what I was saying, one of the things that was taken out of context, I have this job because I want it, not because I need it or because I have to have it. So I'm here because I want to be. I'm here because I'm a West Virginian who cares desperately about West Virginians. And it's not worth it to me to lie to the people I care about the most. And so had I been asked to lie, I would have quit the job and then told everybody what I knew to be the truth. Because life is too short, and that is not who I am. I'm not elected. I don't have a constituency to make happy. My overriding concern has always been and will always be the health and well-being of West Virginians. And so for me to have failed in this communication wounds me desperately, and it breaks my heart. And we are still struggling to help people understand the situation and to have faith in their water. I mean, water is primal. It's what leads everything. And I will tell you, I almost never drink from water bottles anymore. I always drink tap water so that when I'm seen out in the community, people can see me drinking the tap water and they can know that I wasn't just saying it, I meant it. So communication, it's critical. This gives you a little bit of an understanding of kind of how we operate during an emergency. I got called at a couple minutes to 5 p.m. on January 9th. Now, I started the cascade because that's when I found out that the MCHM was in the water company's system and they weren't able to control it. So, and it was going to be in the water. And I can tell you on January 9th, we didn't know much about MCHM. Today, if you would like, I can draw the chemical structure for you with the bonds so you can see. But to be safe, we said, don't use it, don't drink it, don't cook with it, don't drink it, don't boil it, all of these things. But this started a huge cascade. I mean, it involved federal agencies, it involved the National Guard, it involved the CDC, it involved the EPA, all of whom were involved within the first hour. It involved FEMA. It involved ATSDR, which is, I can't believe I'm blanking on it, it's Toxic Substances and Disease Registry agency for all that. The NIH, it involved the National Toxicology Group. It involved contacting local health departments. At first, it looked like it was just going to be Kanawha County, and then it became clear it was going to be a lot larger than that. I was also in that first hour on the telephone with the CEOs of hospitals, telling them they needed to cancel their elective surgeries. This was on a Thursday, cancel their elective surgeries on Friday, start implementing their emergency plans for alternative water, to make sure that the word got out to turn the water off in the hospital so people weren't using it to wash their hands or what have you. It also shut off the autoclaves, which they use to sanitize surgical instruments. So all this is in the first hour. Then we've got the media calling. We've got legislators, both federal and state, calling. It involved my epidemiologists from my Office of Epidemiology. It involved my Office of Environmental Health Services. They are the people who monitor under the Safe Drinking Water Act. We get all of the reports. The other thing I did was I called for 10 years of American Water Company's past reports to see if there were any deficiencies or any issues. There were none. It involved my state lab. Once again, this is a new chemical we don't know a lot about. The manufacturer was not forthcoming. I'm also not sure how many of you in here are aware, you know what a material safety data sheet is. And all chemicals are required to have a material safety data sheet. But what you may not be aware of is they're not required to be accurate. So, that's another challenge that we all face. That being said, our state lab, working with the National Guard lab, working with the EPA, working with some private labs who stepped up to help, we had to develop a way to test for this chemical in the water. And then we had to make sure we could replicate it and that it was accurate. All of this is going on simultaneously. In the meantime, you know, I've got my epidemiologists working on contacting hospitals, tracking ER visits. Interestingly enough, there were no ER visits prior to our announcement of do not use, and a surge after our announcement of do not use. The other thing I will tell you about the Kanawha Valley is DuPont had a drill chemical spill, and they announced they were having the drill chemical spill, and I believe it was 10 or 15 people came to the emergency room with symptoms from the drill chemical spill. That being said, so we do have some challenges in that area. And then we also had toxicologists trying to help us. Poison Center stepped up and was operating 24/7 to help us handle the calls of concern, genuine concern from the public. We set up health and medical command. That's what my Center for Threat Preparedness does. We do this whether it's a water situation, whether we did it in Derecho, we did it for Hurricane Sandy, we do it for if there's severe flooding. We have this ability to bring people together, reach out to regional centers for threat preparedness throughout the state and mobilize things quickly if needed. For example, the flooding in McDowell County, they were short tetanus shots. We were able to get shots from different counties and get them delivered within the hour upon knowing that there was a shortage. So it's a really good system and it works very well. Nobody knows about it because it's not exciting and it's not what the press covers, but It's a fantastic group of people who, by the way, do not get paid overtime, who are state employees, who come in and voluntarily man this. They man the phones, they man the computers, they help the communication to keep this going 24/7 for as long as necessary. So it's amazing to see it go. And then the state has its own emergency operations center out of Homeland Security, and they also help us manage all of this. And then we had a joint information center. Needless to say, it was a lot of late nights, many days, lots of weekends, dealing with this immediate crisis. We didn't know what we had, but this just kind of gives you an idea. You know, like I said, we've got questions from the general public, but then we've got the media coming in. It was a big response. But this is what happens every time we respond. The other thing, one of the things they asked that we talk about today were about social determinants of health. And I think I've touched on this a little bit already without actually perhaps calling it the social determinants of health. And I think I say this like this is while data is very valuable and it's important, it's only one factor. We have to figure out where people were born, how they were born, where they've lived, where did they grow up, what are their family experiences. It's like for child abuse. We know that a child that is abused is more likely to be an abuser when they're an adult and a parent themselves. So how do we break the cycle? We know that culturally it's acceptable to smoke, so how do we change the culture? And we have to look at where people have grown up, where they live. You know, if grandma and grandpa have smoked their whole lives and they're 86 and they haven't suffered any ill effects because they happen to be genetically blessed, that doesn't necessarily that's going to be true for Joe the Third, okay? But that's not what their experience tells them. Their experience tells them that they can smoke and they're going to live to be in their 80s and they're going to be fine. So how do we make them understand that what they've experienced may not be the actual truth? And this is what social determinants of health are. It's looking at circumstances that are shaped by many, many different things. Not just genetics, but also by economics, by policies, and politics. So, and the other thing, and with that politics, also to the infrastructure, and what's something that I think is incredibly critical here in West Virginia is access. And access is down to roads. There are places in this state that if the weather is bad, they are inaccessible. 2014, they are inaccessible. So infrastructure, roads, bridges, not just hospitals and institutes of learning, basic things. How long does it take the ambulance to get there? Can a helicopter land there? These are all important questions. And then it says, so I have the patient, they're transferred to Charleston, they're seen, we send them home, we tell them to see their doctor, only they don't have a car, and their doctor got set up with is in Charleston, and the first time they came to Charleston, they came in an ambulance, and maybe they went home in an ambulance. So how are they going to get back for their follow-up visit? And there's no doctor in their town. Hardy County, 2 physicians, one of which has been there his entire career and is close to retirement. and he also serves as the part-time health officer in the local health department. We are an underserved state medically. In Morgantown, Charleston, Wheeling, Beckley, Clarksburg, Parkersburg, Huntington, you can get care. But, you know, in War, Pincher's Holler, much more difficult. So, genes and biology do play a role in somebody's overall health. But health behaviors also play a really large role. You know, do you use illegal drugs? Now, I did have a patient tell me once, now, Dr. Tierney, I don't use any of those illegal drugs. I only shoot up my OxyContin. So, there you go. So, are you using illegal drugs or drugs that were A, not prescribed for you, but for somebody else, or B, prescribed for you, but you're adulterating them to take them in a different way? You know, but it's also about unprotected sex. It's about making the choice to smoke. It's about binge drinking. There's also social environment and social characteristics, whether it's the feeling of discrimination, if that's because of your race, if that's because of your sex, if that's because of your sexual orientation, if it's because you're going through a gender transformation, or is it because you feel like you're poor, and because you're poor, nobody's going to listen to you? We get all of that. And then there's the physical environment, which we talked about, such as roads and access. And then, if you can get there, if you can get access, do you have quality health care waiting for you? And if you do have quality health care waiting for you, can you then afford the medications that have been ordered for you? Or can you afford the follow-up tests? So social determinants of health represent social environment, physical environment, and health environment. You all provided me with this slide, and I appreciate it. It's a wonderful illustration of how policy impacts different areas of the social determinant realms. Because communities are unique, we need partners and stakeholders in those communities at the table, once again, so we can understand what that community's needs are. Is that parents? Is that the elderly? Is that the infirm? Is it schools? Is it faith-based? Is it all the above? Our goal is to achieve health equity. Health equity is a big word. What does that mean? It comes down to when everybody, and this is from the CDC, so I want to make sure I get it right, when everybody has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. And so it's the absence of systematic disparities in health between and within social groups that have different levels of underlying social advantages or disadvantages. That is, different positions in the social hierarchy. And that is what we strive for. I strive to engage the disenfranchised who feel that they don't have a place at the table, they don't have a place with us. So I think we've talked about all of this. I'm going to look at some of the data. Our three big ones here in West Virginia are obesity, tobacco use, and overdose drug deaths. We do the behavioral risk factor surveillance system. BRIEFUS is what is called. This is a sampling of West Virginians. These are self-reported. So if we look at that, and you look at some of the data from just 2012, and we're working on 2013s right now, West Virginians feel that they have, a full fourth of our population feels that they have fair or poor general health. And I think that's accurate. That ranks us second in the United States. So if we look at obesity and we look at West Virginia's totals, we're at 33.8%. This is by BMI. For the United States, it's 27.7%. We're ranked third highest. We're no exercise. And so when we say there's no exercise, this is what I'm talking about, getting into the community and understanding. Do they not exercise because there's no place for them to walk? If they walk out on the street, there is no street. It's a two-lane curvy road, and they're likely to get hit by a coal truck or a tree truck or some other car speeding along. Would building a sidewalk change that statistic? Or if we had a safe place for them to go and, like I said, swim in a community pool, would that make a difference? And then because we are overweight and obese, and because we don't exercise, we also have the highest prevalence of heart disease, and we have the second highest prevalence of diabetes. So obesity for 2013, according to the Robert Wood Johnson Foundation, 31.5%, identical for West Virginia and Mississippi. But when you look at the statistics, there were 20 other states that were within percentage points or fractions of percentage points of West Virginia. So this is not just a West Virginia problem. This is a nationwide problem of, in a sense, of overabundance and choice, lots of opportunities for bad choices. I always like to tell my pediatric patients, especially those on a limited budget, that a bag of fresh apples costs less than a bag of potato chips. And the apples will give you more snacks, more nutrition, and are better for you than that bag of potato chips. And so sometimes that worked and sometimes that didn't, but I always thought it was an important point to bring up. This is just a schematic of our obesity issue. I would love for West Virginia to move away from the purple. And like I said, the obesity leads to other problems. 41% of West Virginians have hypertension, high blood pressure. 41% of West Virginians have high blood pressure. High blood pressure leads not only to the heart disease, but it can also lead to stroke. And these are things that we continue to work on. We have started a cardiac project. It's still in its early phases. We are seeing some early trends that are positive. It's working with kids, getting them moving 30 minutes per day of physical activity in school. It's also teaching them about healthy choices. Now, the problem with children are they don't buy the groceries, and they eat what they're fed. But it's still important to help them understand about their choices and about choices that they can make. And I know we talked before about politics, I will not tell you the struggle we have trying to get soft drinks out of schools, out of being provided by SNAP. And I have the same struggle trying to get sugar juice drinks out of WIC. I will tell you, the Bureau, we have about 16 different initiatives, all are brand new, that we're trying to target obesity. And we're trying to go to the community level. And we're hopeful to have some data before long that's going to show us maybe what's working in some places and not working in others. And then we can share the successes and see if we can't implement change. Some of the fun things are like the Senior Olympics, getting people who don't want to move. And then for the kids, the Xbox Get Connected. It's sort of like the Wii Fit, but the kids are much more engaged because it's a video game. I'm like, if that's what it takes, let's try it. And like I said, we've got many. And we're happy to sponsor these programs. But once again, we can only take it so far. People in the community have to stand up and take ownership of these programs and help implement them. And like I said, we've got a lot of going on that. This is some good news that we've seen. Less than 15% of West Virginia schools allow soda to be purchased. That's a huge change. I would like it to be 0%, but I'm glad we're down to 15%, and it's been a big struggle. Next, we got to work on these sports drinks and these energy drinks that are empty calories. You see that 55 to 65% are prohibiting advertising in their sporting events or whatever of the candy and other junk food. A lot of them, 75%, are allowing students to have water bottles with them during the day. And 95% are offering free sources of water for the kids. So these are positive trends that hopefully are going to translate into positive answers, but this is going to take us a while to find out. $120 million spent in West Virginia advertising tobacco. Plus, we've got a strong tobacco culture here. We have had some positive trends here too. Oops. We'll come back to that actually. These are the positive trends. 124% increase in the number of high school students who have never used any form of tobacco. That means these are teenagers who aren't smoking, who are going to be parents in the next 10 years, some of them, and they're going to be raising children in smoke-free homes. So this is a real chance at a culture change for our communities. 107% increase who have never even tried a cigarette, and a 52% decrease in those who are actually currently smoking in our high schools. So this is good news. Here's the bad news. These new little things called e-cigarettes that are out here, that are neat and new, and they don't, they light up and they give us smoke vapor. And the tobacco companies are marketing them as a cleaner alternative to smoking, which troubles me on a variety of things. First of all, they still have nicotine. Nicotine is the addictive drug. 2, tobacco companies don't exactly have a great track record for being honest with the public about health effects of their products. 3, they say that this is a way to quit tobacco. Well, The tobacco company is not in business to help people quit smoking. They're in the business to try and get more people to smoke, and this is the way they're doing it. If our kids start picking up these electronic cigarettes and get addicted to nicotine, then, and by the way, they say that it's a cleaner alternative. We have no evidence of that. And the studies that are starting to come out from people who are not related to drug companies are not supporting that claim of them being cleaner. But if our children start picking these up and start smoking with them and get addicted to nicotine, all of our positive strides are going to come to an end. They are marketing these towards teenagers and young adults. And the nicotine is what causes the vasoconstriction, which causes, just so for you who don't have a medical background, causes all the bad things that happen, like for a pregnant woman who smokes. All of those things still happen with this. So these are still dangerous, dangerous things in a pretty package. To me, it's no different than when they had Joe Camel, the cartoon, and were doing it for children. This is all they've done. They've just taken the cigarette and put it in a new pretty package. These are incredibly dangerous. And they threaten all of the good strides that we've made so far. This is one of our success programs, RAISE programs. They're in a lot of high schools. They are done by teenagers, for teenagers. This is not me telling a teenager not to smoke. You know, I mean, those of you who have any familiarity with younger teenagers, I don't know how we possibly lived this long, as stupid as we are. But, you know, they respond much better to other teens. And this has really taken off in our schools. What I like is they use lingo that the teens respond to. Things like they tell them to rebel against tobacco, and these are crews, not groups or clubs. These are crews, raised crews. So all of these things are speaking their language and is obviously resonating with them. So like I said, this is one of those programs that we're going to keep funding because we're seeing really great success. And then drug overdose. It's a good and a bad. This is sort of, you know, all the stuff in the news. None of this is a surprise to anybody. We've led the country with drug overdose deaths. We're seeing, as you can tell, a tremendous increase in heroin overdose. This is not unexpected because heroin is the drug of choice for those addicted to opiates. When they can't get their opiates, then they're going to go to heroin. Heroin, at this point, is a lot cheaper than many of the drugs that you can buy. Oops, I did something. Can you save me? There we go. And you see the drug overdose deaths are declining. But as we're seeing the heroin increase, that means we're really not making much improvement, and that this number is misleading because it's a result of the tightening from the legislature, several laws putting a lot more restrictions on the prescribing of narcotics. So more people are turning to heroin. Even though the number is starting to trend downward, that's still a horribly high number. And this is going to require a lot. It's going to require more than legislation. It's going to require more than the state saying you shouldn't do it. This is one of these places where it's going to require multiple people at the table. this is going to be a community-driven event, that's the only way this is going to get better. You can keep legislating the doctors. The reality is the majority of the drugs that are out there are not coming from the physicians. And they are coming from places you would not believe. A huge percentage of people take relatives' drugs, so drugs that is legitimately prescribed for somebody, they're taking it. Some of these people, because of poverty, and here's some more of our social determinants, because of poverty, are selling some of their drugs that they need to make rent. So some of these older folks who maybe have a Lortab prescription can make more money by selling a couple of their tablets and just kind of make do with what they've got left. Like every field, there are some bad actors. In medicine, it's getting harder for them with the drug control system, and every prescription now is reported to a database. And we've also started a pact with surrounding states so that before long, physicians are going to be able to see not only if you've had a prescription filled in the last 30 days, where did you have it filled? Did you have it filled in Kentucky, or did you have it filled in West Virginia or Pennsylvania or Virginia? That sort of thing. Additionally, they're identifying both doctors who are prescribing out of the norm, and they're identifying patients who are doctor shopping. So, like I said, as it becomes more difficult, we're going to see more heroin. Oh, and we have the second highest age-adjusted death rate per 100,000 population. A lot of this comes from, you'll have to excuse me, sheer stupidity. This is the riding the four-wheeler without a helmet or without safety gear, or after you've been drinking. This has been drinking in a car and you get mud in the tailpipe, and just like the guy from that TV show, you know, end up killing yourself and everybody else in the car from carbon monoxide poisoning. A lot of this is preventable deaths. That also is a cultural change, you know, wearing a seatbelt. You would think, I think everybody knows you should wear a seatbelt, but yet there's still a large portion of our population who don't wear seatbelts, and we know seatbelts save. So how are we going to motivate them to change their behavior? Now what? Once again, it's going to take a community. It's going to take all of us. It's going to take thinking about things in a different way. It's going to be about not collecting data for data's sake. It's going to be about not looking to the state and expecting the state to have the answer. It's about figuring out who is your audience, what can you do to motivate them, what can you do to make things better. It's about having the belief that just because this is the way things have always been doesn't mean that's how it has to be going forward. It doesn't mean that we can't embrace our traditions without getting rid of some of the more harmful portions of them. And it's about figuring out how to do that and how to do that effectively. And so I think I have more questions than answers for you at the time, for the time being, but I will leave you with that thought, that this is something for us all to think about. And I thank you for your time.
Okay, we're going to change it up a little bit and ask Commissioner Tierney to take a couple of questions. We're going to put a chair out here for you to rest while we handle questions. And if you have questions, please hold up your cards so that we can collect them and begin the Q&A process. We do have some initial questions. Put it on the other side over here. Why, thank you very much. I appreciate that. Yeah, I'm going to give you a mic. There you go. Okay. So the first question that we had was about community. And it's related to federal funding and decisions that are made about distributing funds across the state of West Virginia to local communities and local health departments. Can you talk a little bit about how those decisions are made and how you handle that?
Sure. One of the first things to think about is, what is a community? A community can be as small as a school or as large as the entire state. So it depends on what the project is and how that's taken into account. I will say sometimes it's population-based. We have to, what you need to remember with grant funds, particularly federal grant funds, is they are awarded to us with very specific guidelines. And so we have to follow those guidelines when we make decisions. So sometimes it is population-based. Sometimes it is infrastructure-based. Sometimes it is, you know, is this community have the leadership in place in order to implement the program? Or do they have identified people or groups who are willing to take a new project and try to move it forward? So that's kind of what we do with communities and how we decide. No one grant, there's no one formula for all grants. Each grant is unique and each decision is unique. And it may not feel like it sometimes, but we literally get together and discuss the pros and cons and make some very difficult decisions. Our federal dollars, much like our state dollars, are getting much tighter. And it's a very difficult time right now.
Dr. Tierney, you mentioned Pincher's Holler and the fact that they had been without water for a very long time. I am wondering if the Charleston incident gave us an opportunity to address other locales around the state that had been without water for a long time, if that propelled that issue.
It really didn't help it much. I tried to bring it forward and as something that needed to be considered during the legislative session, but that didn't really get, and let's be honest, it's politics, it didn't get news play. And because it didn't get news play, they weren't interested in talking about it. Now, that's not everybody, and that's not all things, and that's a sweeping generalization. But really, nothing that was done is going to help Pincher's Holler very much.
Okay. Someone asked about prevention and wondered if the costs to the state to prevent the water crisis versus having to respond to it had been looked at, and what your thoughts are about that.
It's very difficult to prevent something that you're not expecting to happen. That being said, it's also mind-boggling for a lot of people to understand that the state, not just public health, but DEP, have or had at least no power to investigate or to inspect. And the companies were under no obligation to tell us what they actually had stored. It might also interest everybody to know that there's only 40 substances, 40 chemicals that are considered dangerous that are on a list. That list was compiled in the 1970s and hasn't been updated since. So if you're not on that list, you don't have to disclose hardly anything. And so it's not, it shouldn't, I guess, been an unexpected thing that maybe this could have happened. A lot of other things that people have said is One, why didn't the water company shut down its intake? Well, that's more of a question for the water company. The reality is it's not so easy to shut an intake. The other thing is they have a very sophisticated system that they initially believed was going to be able to handle it. And they do have water tanks, and they have storage for about 3 days. They actually have the space for about 5 days, but they can't keep 5 days worth of water because then the water fails to meet the water quality standards set forth by the EPA. So they, like most water companies across the country, have about 3 days stored water. That wouldn't have got us through this situation. There's also decisions about sanitation. If we shut off the water, people can't flush their toilets. You know, it's in the middle of the winter. These are all serious sanitary concerns. And additionally, if the water pressure drops, then there's no ability to fight a fire. And because the system is an old system, there are new parts connected to old parts, connected to older parts, connected to new parts. There's concern, particularly in the winter, about the pipes not being able to handle the loss of pressure, then pressure, the loss of pressure, and then the pressure. That's why we had zones flush at a time, because we had to make sure that water pressure didn't drop. Water pressure drops, then we have clean water, but then we're looking at a boil water thing following that. That would have been really well received. So there were a lot of considerations going on, and the water company and the officials who were there had to make a quick decision about whether to keep the water going or to close it down. It's not like they had several days to consider the options. They you know, I think made the best decision they could make in the situation.
Okay, thank you. I have 2 more questions. If there are any other questions, would you please let us know? So there's a card over there. So one of the questions is about dental issues in the state of West Virginia and fluoridation of the water. Can you say a little bit about that?
Yeah, the good thing about West Virginia is the majority of our water systems do have fluoridation. It is a key public health initiative to keep fluoride in the water. It's also one that's constantly under attack. And so each year before the legislature starts, we prepare all of our arguments on why it's important to have fluoridation in the water. And I think that it's great that somebody's thinking about that. And I would ask you to please make sure you tell your delegate and senator how important it is to have fluoride in the water.
Okay, so I want to close on a positive note. Yeah, and there is one more question. I'm going to save this last question. I hope I can read your handwriting. All right, so this is, how can West Virginia address the underlying threats to water quality and availability from ongoing energy development issues? Is that a tough one? Can you say something?
It is a tough one, and I know we're talking about fracking. And I'd be lying if I sat up here and said I have all the answers. I will tell you that the Senate Bill 373 now has caused West Virginia to have the most stringent water bill in the country. So if there is a way to do it, we will do it. I mean, like I said, water is primal. We get that. at the same time, we have to balance that with our economic needs. The state is hurting, and we need new industry. I always said, why do I have to be a friend of coal or a friend of the mountains? Why can't I be a friend of both? That somewhere there has to be a middle ground where we take appropriate precautions, but yet we can still achieve our goals, still keep people working, still keep getting tax dollars. A lot of people don't want to talk about, what these industries do for the state. And it's not just being pro-coal. Their tax dollars fund my health programs. Their tax dollars pave the roads. And so we have to figure out a way that we can go forward together to protect our water and our beautiful, beautiful environment and our nature, but at the same time access our assets and put people back to work and increase our viability.
Thank you. This is the last question that I have. When you first started your presentation, you put up the org chart for the Bureau, and you said this was tremendous. And next month you will have been in the job for 1 year. Can you talk a little bit about why you went in this direction and what's going to keep you going?
I have always wanted to help people. I was always everybody's mother. I was always wanted to help. It's one of the reasons that why I left practicing law on a full-time basis. I didn't feel like I was helping anybody. And so when I reevaluated and said, where can I go? Go back, I went to med school. And let me tell you, the privilege of being a physician is just that. Being able to take care of somebody in that fashion is a tremendous privilege, and something I absolutely love doing. And so when I chose to leave clinical medicine and move to public health, it was with the hope that instead of affecting or helping one person at a time, that I could help thousands at a time. And that hope continues. So being a West Virginian, having generations of West Virginians in my family, and hoping to have generations in the future, all of this is very important to me. I guess the reason I did it is I care, and I hope I can make a difference.
Thank you very much, and I think that's an appropriate note to end on. See everybody next month in November, and please complete your evaluations and leave them for us to get. Thanks for coming today.